You enjoy intimacy. Most adults do. But here's the question. People are often too embarrassed to ask honestly. What kinds of sexual activities are Americans actually interested in, and how common are the things many people privately assume are unusual? Men regularly come into my office worried that a particular desire makes them strange, that something their partner suggested must be abnormal, or that everyone else is having a completely different kind of intimate life. In most cases, what creates the anxiety is not the desire itself. It is the silence surrounding it. I'm Dr. Emily Carter, and today we are breaking down 10 of the most commonly reported sexual activities among American adults, using findings from one of the broadest nationally representative surveys conducted on sexual exploration in the United States. Before we begin, tell me where you're watching from in the comments and subscribe for more honest, respectful discussions about men's health, sexual wellness, relationships, and confidence. Stay with me because numbers 9 and 10 are much more common than most people assume. There is one important clarification before we begin. This was not an official countdown in which researchers ranked every activity from America's favorite to least favorite. The study examined whether people had ever participated in a wide range of behaviors, whether they had done them recently, and which behaviors they found appealing. I have organized several of the most commonly reported activities into a simple countdown for this video. A person reporting that they tried something once does not necessarily mean it remains a preference, and something being common does not mean you or your partner are expected to enjoy it. The study surveyed 2,021 American adults, including 975 men and 1,046 women. Participants ranged from 18 to 91 years old, and approximately 91% identified as heterosexual. Because it was a confidential survey, people could report experiences they might never discuss publicly. The results revealed enormous diversity, but they also showed that affection, kissing, closeness, romance, and communication remained highly appealing to both men and women. In other words, novelty may attract attention, but emotional connection still matters enormously. Number 1 is vaginal intercourse. This is the least surprising activity on the list and remains one of the most widely reported forms of partnered sex. More than 80% of adults in the survey reported having experienced it during their lifetime. For many couples, it represents physical pleasure, emotional closeness, reproduction, or some combination of all three. But familiarity does not automatically create satisfaction. Long-term couples sometimes focus so heavily on completing the activity that they stop communicating about the experience. Healthy intimacy is not measured simply by whether intercourse occurred. Comfort, consent, emotional presence, protection, pacing, and mutual pleasure are equally important. Many couples improve their intimate relationship not by searching for a dramatically different activity, but by slowing down, communicating more clearly, and becoming more attentive to one another. Familiarity becomes boring only when curiosity and communication disappear. Number 2 is masturbation or self-pleasure. More than 80% of respondents reported having experienced it, making it one of the most common sexual behaviors in the study. Despite this, many adults still carry shame about it because of cultural, religious, or family messages received during childhood. From a clinical perspective, masturbation is generally considered a normal part of adult sexuality when it is private, consensual, and not interfering with relationships, responsibilities, sleep, or daily functioning. Self-pleasure may help a person understand what feels comfortable and communicate those preferences more clearly to a partner. It can also provide a sexual outlet when someone is single, separated from a partner, or experiencing a difference in desire within a relationship. The concern is not simply how often it occurs. The more useful question is whether the behavior remains under your control. If it begins replacing relationships, disrupting work, causing physical irritation, or feeling compulsory rather than chosen, that is when it deserves closer attention. Number 3 is oral sex, both giving and receiving. More than 80% of participants reported experiencing oral intimacy at some point, making it far more common than many people openly acknowledge. For many couples, it is an important part of mutual pleasure because it expands intimacy beyond intercourse and encourages partners to pay closer attention to what one another enjoy. However, oral sex is not completely free of health risks. Infections including herpes, gonorrhea, syphilis, HPV, and others may be transmitted through oral contact. Condoms and dental dams can reduce the risk, particularly with new partners, or when STI status has not been discussed or confirmed. Regular testing and honest conversations about sexual health are not signs of distrust. They are signs that both partners value one another's well-being. CDC number 4 is watching sexually explicit material. The survey found that approximately 82% of men and 60% of women had watched sexually explicit videos or DVDs at some point. These figures describe lifetime experience, not necessarily frequent or current use. Some people use adult content occasionally out of curiosity, for arousal, or as part of a consensual experience with a partner. Occasional viewing does not automatically mean a person has a medical or psychological problem. The concern begins when viewing feels compulsive, consumes increasing amounts of time, interferes with sleep or responsibilities, replaces real intimacy, or creates unrealistic expectations about bodies and sexual performance. Adult entertainment is produced for visual impact. It does not represent how communication, consent, preparation, comfort, and pleasure normally unfold between real partners. If someone finds that ordinary intimacy feels less stimulating without increasingly specific material, taking a break and discussing the pattern with a qualified clinician or therapist may be helpful. Number 5 is wearing lingerie, special underwear or clothing chosen specifically for an intimate moment. Approximately 75% of women and 26% of men reported doing this. What makes the activity appealing is often not the clothing itself. It is the message behind the effort. Choosing something special communicates anticipation, intention, and the desire to create an experience rather than simply waiting for one to happen. This can be particularly valuable in a long-term relationship where familiarity has gradually replaced deliberate romance. Novelty does not require extreme behavior or expensive purchases. It may involve different clothing, better lighting, planning uninterrupted time together, or simply making it clear that intimacy is being approached with intention. The most important requirement is that the person wearing it feels comfortable rather than pressured to perform an identity that does not feel natural. Number 6 is sending or receiving intimate photographs and suggestive messages. The study reported that approximately 65% of men and 54% of women had sent or received nude or semi-nude digital images. For consenting adults in a trusted relationship, intimate messaging may build anticipation and maintain connection across distance, but it also carries a level of risk that disappears the moment an image leaves your device. Relationships end, accounts may be compromised, devices may be lost, and images can be shared without consent. No image should ever be requested through pressure, threats, manipulation, or repeated asking after someone has refused. Never create, request, possess, or share sexual images involving anyone under 18. Between adults, consent to receive an image is not permission to save, display, or forward it to someone else. Digital intimacy should be approached with the understanding that complete control may be lost after pressing send. Number 7 is reading erotic stories. Approximately 57% of survey participants reported having read erotic literature. This activity receives less public attention than visual adult content, but it demonstrates something important about sexual response. Arousal is not purely physical or visual. Imagination, anticipation, language, emotional context, and fantasy may all contribute. Erotic fiction allows adults to explore ideas privately without necessarily wanting to recreate every scenario in real life. Fantasy does not automatically equal intention. A person can find a fictional situation exciting while having no desire to experience it outside the imagination. Some couples use stories as a way to begin conversations about preferences, but no partner should assume that enjoying a story creates consent for the activities described in it. Number 8 is sex in an adventurous outdoor or semi-public location. At least 43% of respondents reported some form of public or potentially observable sexual experience during their lifetime. The appeal is often connected to novelty, spontaneity, adrenaline, and the feeling of breaking routine. But this activity carries obvious privacy, consent, safety, and potential legal concerns. The presence of people who have not consented to observe sexual behavior changes the situation completely. What feels exciting to a couple may be upsetting or inappropriate for an unwilling observer. There is also the possibility of being recorded, interrupted, injured, or confronted. Couples attracted to the idea can create novelty in a private setting without exposing strangers or placing themselves at unnecessary risk. Adventure should not require ignoring the rights and boundaries of everyone nearby. Number 9 is anal sex, and this is one of the findings many viewers may not expect. The study found that approximately 43% of men reported having been the insertive partner, and approximately 37% of women reported having been the receptive partner at some point in their lives. Once again, this represents lifetime experience, not necessarily a current or regular preference. It also does not tell us whether every experience was enjoyable. Anal sex requires more preparation than many other activities because the rectum does not naturally produce lubrication in the same way vaginal tissue does. Communication, sufficient lubricant, a slow pace, and stopping when there is significant pain are essential. Condoms can reduce the risk of STI transmission, and a new condom should be used when changing from one type of sexual contact to another. Oil-based products can weaken latex condoms, so water or silicone-based lubricants are generally the safer choices with latex. CDC, this activity should never happen through pressure or surprise. Consent needs to be specific. Agreement to one sexual activity is not automatic agreement to another, and a partner has the right to change their mind at any stage. Persistent pain, significant bleeding, or continuing discomfort afterwards should be discussed with a healthcare professional rather than dismissed as something a person simply has to tolerate. Number 10 is consensual spanking or playful impact. At least 30% of the surveyed adults reported spanking or being spanked during sex, making it considerably more common than the silence surrounding it suggests. Some couples experience it as playful, exciting, or connected to a consensual exchange of control. Others have no interest in it at all. Both responses are completely valid. The word consensual is the most important part of this activity. Partners should discuss boundaries before beginning, agree on what level of contact is acceptable, identify areas that are off limits, and establish a clear signal for slowing down or stopping. Consent should be enthusiastic and ongoing, not assumed from silence. Intentionally frightening, hurting, restraining, or striking a partner without agreement is not experimentation. It is abuse. Even consensual impact requires basic physical caution. Avoid striking the head, neck, spine, kidneys, joints, or any injured area. Start gently rather than attempting to reproduce something seen in adult entertainment. Check in afterward for pain, bruising, emotional discomfort, or a changed feeling about the experience. A safe word is useful only when it is respected immediately. Looking at this entire list, the most important finding is not that Americans are secretly doing one shocking activity. It is that sexual behavior is much more diverse than most people realize. Traditional intercourse, masturbation, oral sex, lingerie, fantasy, digital communication, adventurous settings, anal sex, and consensual impact all appear in the experiences of substantial numbers of adults. But popularity does not define what is healthy for you. A healthy, intimate activity involves consenting adults, honest communication, respect, reasonable physical safety, and the freedom for either person to stop. Something does not become healthy merely because millions of people have tried it. It does not become unhealthy simply because it is less common. The context, motivation, consent, and effect on both partners matter more than the ranking. I want to leave you with 4 practical principles. First, talk before you experiment. Asking your partner what they enjoy is not awkward. Assuming is far riskier. Second, protect your health through appropriate barriers, STI testing, contraception when pregnancy is possible, and honest disclosure of relevant risks. Third, begin slowly. Novelty is most enjoyable when both people feel relaxed enough to communicate. Fourth, never use a statistic to pressure a partner. Saying that millions of Americans do something does not create an obligation for anyone else to participate. You also do not need to attempt every activity on this list to have a fulfilling, intimate relationship. Many couples are happiest with a small number of familiar activities combined with affection, trust, communication, and emotional safety. Others value variety and exploration. Neither model is automatically superior. What matters is whether both partners feel heard, respected, comfortable, and genuinely involved in deciding what happens. Another important lesson from this survey is that experience and preference are not the same thing. Someone may have tried an activity once out of curiosity and decided it was not for them. Another person may find an activity appealing in fantasy but have no interest in experiencing it in real life. Someone else may enjoy something only with a specific trusted partner and not consider it part of their general sexual identity. This is why statistics should be treated as information rather than instructions. A percentage tells us how many people reported an experience. It does not tell us what you should enjoy, what your partner should agree to, or what will make your relationship satisfying. I see men make this mistake frequently. They learn that a particular activity is common and immediately begin wondering why their relationship does not include it. Some then approach their partner with a statistic as though popularity creates an obligation. They may say that everyone is doing it, that their partner is unusually conservative, or that refusing means something is wrong with the relationship. That is not healthy communication. A national survey can help reduce shame, but it should never be used as a tool for pressure. Your partner is not a percentage. They are an individual with their own history, boundaries, comfort level, and right to decide what happens to their body. The healthier approach is curiosity without expectation. You might say that you recently learned an activity is more common than you assumed and ask how your partner feels about it, then listen to the answer without trying to negotiate a different one immediately. Sometimes the answer will be enthusiastic, sometimes it will be uncertainty, sometimes it will be a clear no. Each response deserves respect. A person may also need time to think before answering, particularly when the subject involves an activity they have never discussed openly before. Consent is not merely the absence of refusal. Healthy consent is voluntary, informed, specific, and ongoing. A person should not agree because they are afraid of losing the relationship, disappointing their partner, being mocked, or being compared with previous partners. Consent to kissing does not automatically mean consent to intercourse. Consent to one activity does not mean consent to another. Agreeing last week does not remove someone's right to decline today. Even after an activity has begun, either person may slow down, pause, or stop. This may sound very formal when we are discussing an intimate relationship, but consent does not need to feel like a legal negotiation. It can be expressed through simple, natural questions. Does this feel good? Are you comfortable? Would you like me to continue? Do you want to try something different? These check-ins do not ruin the mood. For many couples, they make intimacy more relaxing because neither person has to guess what the other is experiencing. Communication becomes especially important when partners have different levels of sexual desire. Desire naturally changes across life. Stress, sleep deprivation, relationship tension, hormonal changes, medications, illness, pregnancy, menopause, testosterone levels, erectile difficulties, pain, and mental health can all affect how frequently someone wants intimacy. A difference in desire does not automatically mean that one partner is demanding or that the other is rejecting them. It means the couple needs to discuss the difference without turning it into a moral judgment. I often encourage couples to stop using frequency as the only measure of sexual health. One couple may be intimate several times a week and feel disconnected because the experience has become routine or pressured. Another may be intimate less frequently but feel deeply satisfied because both partners are emotionally present and comfortable. The correct number is not determined by friends, movies, social media, or national averages. It is determined by what both people can genuinely agree upon without resentment or coercion. Age also changes the way many people experience intimacy, but change does not mean the end of sexual well-being. Men may notice that erections require more direct stimulation, take longer to develop, or are less predictable than they were in their 20s. The period between erections may become longer. Women may experience vaginal dryness, tissue sensitivity, or changes in arousal around menopause. These are common physiological changes, not proof that attraction has disappeared or that intimacy is no longer possible. Couples who adapt often maintain satisfying, intimate relationships well into later life. Adaptation may involve more time, additional stimulation, a good lubricant, different positions, greater attention to comfort, or medical treatment when appropriate. The difficulty begins when both partners silently expect the body to function exactly as it did decades earlier and interpret every change as failure. Bodies evolve, healthy intimacy evolves with them. For men, persistent erectile difficulties should not automatically be dismissed as ordinary aging. Occasional difficulty is common, especially during periods of stress, fatigue, heavy alcohol use, or relationship anxiety. But recurring erectile dysfunction may also be connected to diabetes, high blood pressure, cardiovascular disease, low testosterone, medication side effects, nerve problems, or other health conditions. The blood vessels involved in erections are relatively small, which means changes in erectile function may occasionally appear before more obvious cardiovascular symptoms. This is why I encourage men to speak with a qualified healthcare professional instead of purchasing unregulated supplements in secret. Many products marketed for male performance contain undisclosed ingredients, questionable doses, or substances that may interact dangerously with heart medication. A proper evaluation can identify whether the problem is primarily physical, psychological, medication-related, or a combination of factors. Effective treatments exist, but the correct treatment depends on the actual cause. Pain during intimacy also deserves attention. Sexual activity should not repeatedly cause significant pain, bleeding, burning, or persistent discomfort. People sometimes remain silent because they assume pain is something they must tolerate to satisfy a partner. It is not. Pain may be connected to inadequate lubrication, infection, pelvic floor dysfunction, hormonal changes, inflammation, skin conditions, endometriosis, prostate problems, or other medical factors. Continuing through pain without understanding the cause can increase both physical injury and emotional anxiety. If discomfort occurs, stop and communicate. More preparation, a slower pace, a different position, or additional lubrication may solve a temporary issue. Persistent or severe pain should be evaluated by a clinician. Seeking help does not mean the relationship is broken. It means the couple is treating sexual health with the same seriousness they would give any other part of the body. Protection remains important, even in conversations focused on pleasure and exploration. Sexually transmitted infections do not always cause visible symptoms. A person may feel completely healthy and still carry an infection. Testing is especially important when beginning a new relationship after unprotected contact or when partners have not agreed to exclusivity. Discussing testing may initially feel uncomfortable, but avoiding the discussion does not reduce the medical risk. Vaccination is another useful form of protection. The HPV vaccine can reduce the risk of several cancers and genital warts associated with human papillomavirus. Hepatitis B vaccination may also be relevant for adults who were not previously immunized. A clinician can review your age, history, and risk factors and explain which vaccinations or screenings may be appropriate. Contraception should also be discussed before sexual activity rather than during an anxious moment when both partners are already highly aroused. Couples should understand what method they are using, how effective it is, and what they would do if the method failed. Condoms help reduce both pregnancy risk and the transmission of many infections, but they need to be used correctly from beginning to end. No contraceptive choice should be secretly discontinued or sabotaged. Reproductive decisions require honesty from both partners. The digital activities mentioned earlier deserve particular attention because technology has changed faster than many people's understanding of privacy. An intimate image may feel temporary when it is created, but digital information can remain accessible indefinitely. Cloud backups, shared devices, automatic photo synchronization, compromised accounts, and screenshots can all remove control from the person who originally sent it. Never share another person's intimate image without explicit permission. The fact that someone trusted you with an image does not give you ownership over it. Sharing it after an argument or breakup can cause severe emotional harm and may violate criminal law. A healthy person protects a former partner's privacy even when the relationship ends badly. Character is often when a sexual interest involves non-consent, significant injury, illegal behavior, minors, or people who cannot freely agree. It cannot be treated as ordinary consensual exploration. A person who is troubled by urges that could harm someone should seek confidential help from a licensed mental health professional before acting. Asking for help is responsible, acting without consent is not. For most adults, however, the central message from this research is reassuring. Human sexuality contains wide variation. Many of the experiences people keep private are shared by millions of others, but normalization should always be paired with responsibility. Common does not automatically mean safe, and unusual does not automatically mean unhealthy. The essential questions remain the same. Are all participants consenting adults? Is everyone comfortable? Are the risks understood? Can either person stop without punishment? Does the experience support rather than damage physical and emotional well-being? Those questions matter far more than whether an activity appears at number 3, number 7, or number 10 on a national list. Statistics can tell us what Americans have tried. They cannot tell an individual couple what intimacy should look like. That answer has to be built through communication, respect, health awareness, and the willingness to care about a partner's experience as much as your own. So, were numbers 9 and 10 surprising to you? And which result did you expect to be much higher or lower? Let me know in the comments, but please keep the discussion respectful. Subscribe for more honest, medically grounded conversations about men's health, relationships, sexual wellness, and confidence. I'll see you in the next video.